Welcome to this audiobook entitled BPS Exam Preparations for Pulmonary Disorders. We will first discuss acute respiratory distress syndrome, abbreviated as ARDS, a definition and epidemiology. 1. It was first described in 1967. A consensus definition for ARDS was proposed in 1994 with the American European Consensus Conference, abbreviated as AECC. It has the following characteristics: acute onset, not defined, PaO2 to FiO2 ratio of 200 mm of mercury or less, bilateral infiltrates on chest radiography, absence of left atrial hypertension, pulmonary artery wedge pressure of 18 mm of mercury or less. Acute lung injury fulfills the same criteria except for a milder pathology for hypoxemia, PaO2 to FiO2 ratio of 300 mm of mercury or less. 2. The AECC definition was refined into the Berlin definition of ARDS, shown in Table 1. Notable differences in the revised definition, published in JAMA in 2012. 3. The reported incidence of ARDS in the United States is 59 per 100,000 person-years. 4. Estimated mortality ranges from 27% to 45%, Berlin definition. 6 variables are associated with increased mortality: age, immunocompromised state, multi-organ dysfunction score, acidemia, barotrauma, and presence of major organ dysfunction on admission, NEJM in 2005. Pause the video and carefully scrutinize Table 1 summarizing the Berlin definition of ARDS. Next we will look at the etiology and pathophysiology of ARDS. 1. Regarding direct and indirect causes of lung injury, A. Direct causes include pneumonia, aspiration, and trauma. B. Indirect causes include sepsis, transfusion injury, pancreatitis, burn injury, and trauma. 2. Hypoxemia develops because of the destruction of alveoli at the cellular level. Destruction of the alveolar epithelium and type 1 and type 2 cells causes impaired lymphatic drainage, disruption of the osmotic gradient, accumulation of cellular debris, reduced surfactant production, and microthrombi. A. The pathophysiologic cellular changes manifest with pulmonary edema, impaired oxygenation, and organ failure. B. The clinical hallmark of ARDS is hypoxemia. C. Regarding non-pharmacologic therapy. 1. The primary goals of non-pharmacologic therapy, e.g., MV-prone positioning, are to support oxygenation and minimize further organ dysfunction. 2. For patients with acute hypoxemic respiratory failure, non-hypercapnic, administering oxygen by high-flow nasal cannula, abbreviated as HFNC, resulted in greater ventilator-free days, 24 plus or minus 8 days versus 22 plus or minus 10 days in the standard oxygen therapy by face mask versus 19 plus or minus 12 days in the non-invasive positive pressure ventilation arm. A reduction in 90-day mortality was also observed in favor of the HFNC group, hazard ratio HR of 2.01 with a 95% confidence interval, CI of 1.01 to 3.99, with a p-value equal to 0.046 with standard oxygen than with HFNC, and HR of 2.50 with a 95% confidence interval, CI of 1.31 to 4.78, with a p-value equal to 0.006, published in the NEJM in 2015. 3. Lung protective ventilation in the form of a low tidal volume strategy, 6 ml per kilogram of ideal body weight, was shown to improve survival in a multi-center study by the Acute Respiratory Distress Syndrome Network (ARDS-NET). It is now the standard of care, published in the NEJM in 2000. A. Targeting a plateau pressure of 30 cm water or less is recommended. B. Permissive hypercapnia P. CO2 of 50 to 55 mm of mercury is acceptable to optimize tidal volume strategy. 4. In a multi-center, randomized trial of 767 patients, a ventilation strategy of moderate PEEP compared with a PEEP level set to a target plateau pressure 28 to 30 cm of water showed no difference in 28-day mortality, but it did show improved ventilator-free days and organ failure-free days published in the JAMA in 2008. 5. A separate multi-center, randomized study evaluated using PEEP as a recruitment strategy to improve ventilation in 983 patients and found no difference in hospital mortality published in the JAMA in 2008. 6. Prone positioning for the treatment of early ARDS less than 36 hours in moderate to severe ARDS PaO2 to FiO2 ratio of 150 mm of mercury or less reduces 28-day mortality compared with supine positioning 16% versus 32.8% with a p-value less than 0.0001 with a hazard ratio HR of 0.44 with a 95% confidence interval CI of 0.29 to 0.67 published in the NEJM in 2013. 7. Next we will discuss extracorporeal membrane oxygenation, abbreviated as ECMO-A. CESAR trial showed that treatment at an ECMO referral center resulted in improved 6-month survival, published in The Lancet in 2009. 1. ARDS with a Murray score of 3 or greater or a pH less than 7.202. Not all patients randomized to ECMO referral center received ECMO treatment. 68 of 90 patients in the experimental group received ECMO. 3. Potential for confounding because of experiential bias. Clinicians at ECMO treatment center may have more experience in treating ARDS. B. The respiratory ECMO survival prediction, abbreviated as RESP, score was developed from a registry of ECMO-treated patients published in the American Journal of Respiratory Critical Care Medicine in 2014. 1. The RESP score predicts patient survival after ECMO initiation. 2. It does not help quantify the decision of whether to initiate ECMO and whether ECMO treatment will improve survival in a specific patient. A global consortium of experts recommended that ECMO be provided in regional centers of excellence with adequate access to clinical support services, staffing, and infrastructure for quality assurance. D. We will now discuss the pharmacologic therapy of ARDS. 1. In a randomized trial comparing optimal fluid management strategies, a conservative fluid management strategy, with CVP less than 4 mm of mercury, compared with a liberal fluid management strategy, CVP 10 to 14 mm of mercury, in patients with ARDS and hemodynamic stability, not requiring vasopresses or MAP greater than 60 mm of mercury, increased ventilator-free days 14.6 plus or minus 0.5 versus 12.1 plus or minus 0.5, with a p-value less than 0.001, published in the NEJM in 2006. Patients with concomitant shock were enrolled in the study and randomized to both treatment arms. If shock was present for patients randomized to the fluid conservative strategy, diuretics were withheld and administered once the patient had established hemodynamic stability, that is after discontinuation of vasopresses or MAP greater than 60 mm of mercury. 2. Early administration of cisatracurium, that is less than 48 hours, reduced mortality in a cohort of patients with moderate to severe ARDS with APA-O2 to FiO2 less than 150 mm of mercury compared with placebo with a hazard ratio, HR of 0.68, with a 95% confidence interval, CI, of 0.48 to 0.98, with a p-value equal to 0.04 published in the NEJM in 2010. 3. Corticosteroids are presupposed to mediate the inflammatory cytokines and mitigate fibrotic alveolar changes during ARDS. Several studies tested the effects of administering corticosteroids during early ARDS and found no benefit. B. A multicenter study of 24 patients with ARDS for more than 7 days reported mortality benefit. Limitations of this study include unbalanced groups, treatment equals 16 patients versus placebo equals 8 patients. In addition, 4 patients were crossed over from the placebo arm to the corticosteroid arm. ARDSnet tested corticosteroid administration in late ARDS, that is ARDS for 7 days or more, and reported no survival benefit, N equals 180. 1. Increased mortality in the subgroup of patients receiving corticosteroids after day 14. 2. However, corticosteroid treatment was associated with improved ventilator and shock-free days during the first 28 days of treatment. 4. Next we will discuss statins. They are presumed to be beneficial by modulating inflammatory response of lung parenchyma. Statins reduced inflammatory response in murine models of ARDS. In addition, observational studies and small randomized controlled trials suggest a clinical benefit to statins for sepsis and ARDS. B. Simvastatin versus placebo published in the NEJM in 2014. 1. Patients recruited from 40 sites in the United Kingdom and Ireland, accruing 540 patients with ARDS, 259 patients randomized to simvastatin compared with 281 patients randomized to placebo. 2. Simvastatin 80 mg daily was compared with placebo. 3. Regarding the outcomes, ventilator-free days, of 28 primary, change in sequential organ failure assessment score, secondary, number of non-pulmonary organ failure days, secondary, mortality, secondary. 4. Regarding ventilator-free days, there was no difference between groups, 12.6 plus or minus 9.9 days simvastatin versus 11.5 plus or minus 10.4 days placebo, with a p-value of 0.21 primary, or with secondary endpoints. 5. Study does not provide support for administering statins for the treatment of sepsis-associated ARDS. C. Rosuvastatin versus placebo, published in the NEJM in 2014. 1. It was a National Heart, Lung, and Blood Institute ARDS-NET study of 44 sites. It involved patients with ARDS, PaO2 to FiO2 ratio less than 300 mm of mercury caused by sepsis. Ventilator management was done according to lung protective, low tidal volume strategy for ARDS. Fluid management was done according to a simplified version of fluid and catheter treatment trial, abbreviated as FACTT. 2. Rosuvastatin was dosed at 40 mg loading dose, followed by 20 mg daily, with a dose reduction for serum creatinine (SCR) greater than 2.8 mg per deciliter to a dose of 10 mg daily, compared with placebo. 3. The outcomes were hospital mortality, primary, ventilator-free days, secondary, organ failure-free days, secondary, and ICU-free days, secondary. It was powered to detect an absolute difference of 9%, 27% to 18%. 4. It was terminated for futility in primary endpoint after enrollment of 745 patients, in hospital mortality, 28.5% versus 24.9%, with a p-value equal to 0.215. Study did not support administering statins for the treatment of sepsis-associated ARDS. Next we will discuss intubation. A. Regarding endotracheal intubation, 1. It provides access for suctioning of tracheobronchial secretions, maintains a patent airway, and allows administration of medications. 2. Its indications include airway protection, facilitation of ventilation and oxygenation, assurance of airway patency, and anesthesia and surgery. 3. Orotracheal intubation is preferred for elective and emergency cases. 4. Nasotracheal intubation is beneficial for patients undergoing maxillofacial surgery or dental procedures and for patients with limited mouth opening. It may be associated with increased risk of bleeding and sinusitis and should be avoided in patients with severe nasal or midface trauma. 5. Its complications include insertion trauma, gastric aspiration, hypoxemia, laryngospasm, esophageal intubation, right main bronchus intubation, cardiac arrhythmias, and hemodynamic impairment. B. Regarding rapid sequence intubation, abbreviated as RSI-1. There is rapid and simultaneous administration of a rapid-acting induction agent and a neuromuscular blocking agent, abbreviated as NMBA, to facilitate intubation and decrease the risk of aspiration. 2. It involves a series of 7 distinct steps, namely preparation, pre-oxygenation, pre-treatment, paralysis with induction, protection and positioning, placement of the tube in the trachea, and post-intubation management. C. Regarding pretreatment, 1. It occurs 3 minutes before any induction agent or neuromuscular blocking agent is administered. 2. The purpose of pretreatment is to attenuate the sympathetic and parasympathetic response, catecholamine release, hypertension, tachycardia, potentially increased intracranial pressure (ICP) in patients with impaired cerebral autoregulation, to laryngoscopy. 3. Fentanyl or lidocaine is recommended for pretreatment, as shown in Table 2. 4. Atropine and defasciculating doses of non-depolarizing neuromuscular blocking agents are not recommended for routine use in RSI for adult patients. Pause the video and carefully scrutinize Table 2 summarizing pretreatment agents. D. Next we will discuss induction agents. 1. They are given as rapid intravenous push immediately before paralyzing agents to help achieve optimal conditions for intubation. 2. These agents should provide rapid loss of consciousness, analgesia, amnesia, and stable hemodynamics. 3. These agents used for induction during RSI include barbiturates, benzodiazepines, midazolam, etomidate, ketamine, and propofol, shown in Table 3. 4. Regarding barbiturates, A. Thiopental is no longer available in the United States. B. Metohexatal is rarely used because of its adverse effect profile, which includes respiratory depression, hypotension, and histamine release. 5. Regarding etomidate, A. Etomidate is a non-barbiturate, imidazole derivative with a rapid onset of action and a very short elimination half-life. B. It enhances the effects of gamma-aminobutyric acid, thereby blocking neuroexcitation and inducing unconsciousness. It does not provide analgesia. C. Etomidate transiently inhibits the conversion of cholesterol to cortisol by inhibiting 11-beta-hydroxylase, leading to transient adrenal suppression. 1. There is no convincing or consistent evidence to suggest that etomidate is associated with an increased risk of death, published in Intensive Care Medicine in 2011 and in Chest in 2015. 2. Large randomized, prospective, adequately powered studies are needed to clarify the clinical significance of etomidate in patients at risk of adrenal insufficiency. Pause the video and carefully scrutinize Table 3 summarizing induction agents. Pause the video and carefully scrutinize Table 3 summarizing induction agents. We will now discuss neuromuscular blocking agents, abbreviated as NMBAs. 1. They are quaternary ammonium compounds that mimic the structure of acetylcholine. 2. They block impulse transmission at the neuromuscular junction, resulting in skeletal muscle paralysis. 3. They are used immediately after induction to help achieve optimal conditions for intubation. 4. They have no sedative, analgesic, or amnestic properties. 5. They are problematic in patients with a difficult or failed airway. 6. Depolarizing NMBAs include the following: A. Succinylcholine. It non-competitively binds to acetylcholine receptors, leading to sustained depolarization of the neuromuscular junction and prevention of muscle contraction. B. It is the best agent for RSI. 7. We will now discuss non-depolarizing NMBAs, shown in Table 4. Examples include A. Rocuronium and Vicuronium. They are competitive antagonists of acetylcholine at the neuromuscular junction, leading to the prevention of muscle contraction. B. Intermediate-acting non-depolarizing agents are alternatives when succinylcholine is contraindicated. C. They usually have a slower onset of action and a longer duration of action. Pause the video and carefully scrutinize Table 4 summarizing common neuromuscular blocking agents. F. We will now discuss post-intubation management. 1. We should provide continued sedation and analgesia as needed to assist in adequate oxygenation and ventilation. 2. We should minimize long-term use of analgesics and sedatives. 3. We should maintain head-of-bed elevation at 30 to 45 degrees. 4. We should do mouth and eye care. 5. We should administer a bowel regimen. 6. We should manage stress ulcer and administer deep venous thrombosis prophylaxis. We will now discuss mechanical ventilation. A. It is critical to understanding how mechanical ventilation works. A fundamental knowledge of acid-base disorders and normal respiratory physiology. B. There are two essential categories of respiratory failure, namely hypercapnic and hypoxic. Arrangements in PaO2 or PaCO2 will help determine the etiology of respiratory failure. Table 2 provides the context for normal oxygenation and ventilation values. C. Modes of mechanical ventilation include the following: 1. A.C. ventilation. A. Regarding volume control. 1. The patient receives a predetermined respiratory rate and tidal volume, with additional patient-initiated breaths provided at the preset tidal volume. Patient-initiated respiration generates a negative pressure within the ventilator circuit, which is sensed by the ventilator, and a full tidal volume breath is provided. 2. It has the potential for ventilator dysynchrony, double stacking, and respiratory alkalosis. 3. It was the mode used in the ARDS-NET study of tidal volume strategy to limit spontaneous tidal volumes, published in NEJM in 2000. B. Regarding pressure control. 1. The patient will receive a breath at a fixed rate until a predetermined peak pressure limit is reached. The tidal volume is variable and limited by the peak pressure limit. 2. It is not ideal for patients with low-minute ventilation and may lead to hypoventilation and further hypoxia. 2. Regarding SIMV, the patient will receive a predetermined respiratory rate and tidal volume plus additional spontaneous, self-generated breaths at whatever tidal volume the patient can generate. It is not ideal for the treatment of ARDS, given the ability of patients to exceed the present tidal volume for spontaneous breaths in excess of 6 ml per kilogram. 3. Regarding PS ventilation. A. It is usually used as a weaning mode of mechanical ventilation from a more intensive mode of mechanical ventilation, i.e., AC ventilation. B. The patient initiates each breath with assistance from the ventilator in the form of a preset pressure value. The ventilator is set to provide a correct amount of pressure to assist each inspiratory effort. The tidal volume and respiratory rate depend on the patient. D. We will now discuss ventilator parameters. 1. Regarding FiO2a. It is the amount of oxygen that is delivered with each breath, from 21% to 100%. B. FiO2 is generally titrated to a PaO2 greater than 55 mm of mercury. The amount of FiO2 delivered is limited by concerns for oxygen toxicity. 2. Regarding tidal volume A. It is the volume of air inspired in a breath, delivered by mechanical ventilation or spontaneous. B. Tidal volume is set according to oxygenation and ventilation needs. Patients with ARDS will be treated with a low tidal volume strategy, whereas most other patients will have the tidal volume titrated to PaCO2 and pH of 3. Regarding respiratory rate A. The respiratory rate is set to provide a minimal number of breaths from the ventilator at the set tidal volume. B. The respiratory rate is titrated minute ventilation, PaCO2, and pH. Minute ventilation, in liters per minute, is equal to tidal volume, in liters, multiplied by the respiratory rate, in breaths per minute. 6.0 liters per minute is equal to 0.5 liters multiplied by 12 breaths per minute. 4. Regarding flow rate, it describes the velocity of air delivered. The velocity is greatest initially on inspiration and decelerates toward the end of the inspiratory effort. 5. Regarding PEEP-A. It is the positive pressure in the alveoli during expiration. B. It provides greater surface area at the alveolar epithelial surface to promote diffusion of oxygen and improve ventilation or perfusion matching. C. It is titrated to meet oxygenation needs. E. We will now discuss quality improvement. Ventilator-associated events, abbreviated as VAEs, published in the American Journal Respiratory Critical Care Medicine in 2015. 1. In 2013, the Centers for Disease Control and Prevention released a model for evaluating complications from mechanical ventilation, and ventilator-associated events. Regarding VAE definition, it entails at least 2 days of increasing ventilator settings, increase in PEEP of 3 cm of water or greater, or increase by 20% or more of FiO2, after at least 2 days of stable or decreasing ventilator settings. Ventilator-associated events can further be subclassified into infection-related ventilator-associated complications, as shown in Table 5. 2. A ventilator-associated events model was developed to enable a population-based method of assessment and tool for quality improvement. 3. Ventilator-associated events are attributed to one of 4 common clinical conditions, namely, pneumonia, fluid overload, atelectasis, or ARDS. 4. 6 potential strategies have been identified to minimize ventilator-associated events, according to the accumulation of data from literature, namely, A. Minimize sedation. B. Paired spontaneous awakening trials and spontaneous breathing trials. C. Early mobility. D. Low tidal volume ventilation. E. Conservative fluid management. F. Conservative transfusion thresholds. Pause the video and carefully scrutinize Table 5 summarizing normal respiratory physiology values. We will now discuss cystic fibrosis. A. Cystic fibrosis is a chronic disease process affecting many organs, including the pancreas, liver, and intestine, but primarily the lung, published in Chest in 2004. 1. Cystic fibrosis is a recessive disorder that is caused by a mutation of the CFTR, cystic fibrosis transmembrane conductance regulator. 2. Acute exacerbations include symptoms of increased cough, sputum production, shortness of breath, weight loss, and a decline in lung function. 3. The lungs become colonized with bacteria, and chronic infections become common. Gradually, the formation of a thick mucus mucoid, harboring Pseudomonas aeruginosa becomes common. B. Regarding antibiotic therapy, 1. Because of the high incidence of resistance, initial treatment with 2 anti-pseudomonal agents is recommended as published in American Journal of Respiratory Critical Care Medicine in 2009. Aggressive dosing of beta-lactam antibiotics is recommended to optimize time above the minimum inhibitory concentration. 2. Antibiotic dosing is challenging because of the altered pharmacokinetics in patients with cystic fibrosis. Patients with cystic fibrosis can be distinguished by their large volume of distribution and increased renal clearance. 3. Evidence is currently lacking for the simultaneous administration of inhaled and intravenous antibiotics for acute cystic fibrosis exacerbations, published in American Journal of Respiratory Critical Care Medicine in 2009. 4. Once daily dosing of tobramycin, dosed at 10 mg per kilogram, to target a peak concentration of 20 to 30 mg per liter and a trough concentration of less than 1 mg per liter, was as effective as conventional dosing, published in Lancet in 2005. We will now discuss the adjunctive therapies for cystic fibrosis exacerbations. 1. Adjunctive therapies for cystic fibrosis exacerbations are key to improving outcomes and mucus clearance. They include a. Aggressive chest physical therapy. B. Dornase alpha administered as a nebulized therapy. C. Hypertonic saline 7%. 2. Regarding nutrition in cystic fibrosis, a. Providing nutrition during acute exacerbations is key to maintaining metabolic function and promoting optimal outcomes for lung transplantation, should the situation arise. B. Administer pancreatic enzymes to assist with digestion. 3. Regarding the use of corticosteroids, there is insufficient evidence for administering corticosteroids. Published in American Journal Respiratory Critical Care Medicine in 2009. We will now discuss pulmonary hypertension, abbreviated as PAH. A definition. 1. Pulmonary hypertension, abbreviated as PH, is a chronic, life-threatening disease defined as an M.P.A.P. of 25 mm of mercury or greater at rest measured by right heart catheterization. No definition of PH is currently accepted during exercise. 2. PAH is defined as an M.P.A.P. of 25 mm of mercury or greater at rest, pulmonary capillary wedge pressure of 15 mm of mercury or less, and elevated pulmonary vascular resistance (PVR) of greater than 3 Wood units measured by right heart catheterization. B. Regarding clinical classification of PH by the World Health Organization, updated at the 2013 World Conference on Pulmonary Hypertension, published in the Journal of the American College of Cardiology in 2013. 1. Patients in Group 1 have PAH. 2. Group 1 have pulmonary veno-occlusive disease and/or pulmonary capillary hemangiomatosis. 3. Patients in Group 2 have PH caused by left heart disease. 4. Group 3 has patients with PH caused by chronic lung disease and/or hypoxia. 5. Group 4 has patients with chronic thromboembolic PH. 6. Group 5 patients have unclear multifactorial mechanisms. C. Regarding functional classification. 1. It was developed in 2004 by the World Health Organization, as shown in Table 6.2. It is used to determine the baseline functional status of the patient and throughout the disease. Pause the video and carefully scrutinize Table 6 summarizing World Health Organization of Functional Class Assessment. D. Regarding the pathophysiology of pulmonary hypertension. 1. In pulmonary hypertension, vascular changes occur, including vasoconstriction, cellular proliferation, and thrombosis. 2. Thromboxane A2, which is a potent vasoconstrictor, concentrations are increased. 3. Prostacyclin, which is a potent vasodilator, inhibitor of platelet aggregation, and has antiproliferative properties, concentrations are decreased. 4. Endothelin-1, which is a potent vasoconstrictor, with mitogenic properties on pulmonary arteries, smooth muscle cells, concentrations are increased. 5. Nitric oxide concentrations, vasodilator, inhibitor of platelet activation, and inhibitor of vascular smooth muscle cell proliferation, are decreased. E. Regarding the treatment goals for pulmonary hypertension, they include to 1. Achieve and maintain World Health Organization Functional Class Assessment, WHO-FC 1 or 2. 2. Preserve 6-minute walk distance to 380 meters or more. 3. Preserve RV size and function, right arterial pressure less than 8 mm of mercury and cardiac index greater than 2.5 to 3.0 liters per minute per meter squared. 4. Normalize B-type natriuretic peptide. 5. Sustain cardiopulmonary exercise testing, including peak oxygen consumption greater than 15 ml per minute per kilogram and ventilator equivalent for carbon dioxide less than 45 liters per minute. F. We will now discuss the management of PAH-1. Regarding supportive therapy, A. Oxygen should be maintained at an SaO2 of 90% or greater and PaO2 of 60 mm of mercury or greater. B. Diuretics should be used for the symptomatic management of RV dysfunction and signs of fluid overload. The choice of diuretic is variable. C. Digoxin will increase cardiac output. Consider it in patients who develop atrial tachyarrhythmias. D. Anticoagulation should be considered in idiopathic PAH, heritable PAH, and PAH secondary to anorexigenic use, GIL INR 1.5 to 2.5. 2. Regarding vasodilator therapy with calcium channel blockers, e.g. diltiazem, amlodipine, or nifedipine. A. They are considered first-line for the treatment of PAH, WHO-FC 1-3, in patients who have a positive response to acute VAS or activity testing, reduction in M.PAP of 10 mm of mercury or more to an M.PAP of 40 mm of mercury or less with unchanged cardiac output, published in NEJM in 1992. B. Around 15% of patients with PAH will have a positive response to the VAS or activity test, published in Circulation in 2005. C. Calcium channel blockers improve M.PAP, PVR, WHO-FC, and survival in patients with PAH and a positive VAS or activity test, published in Circulation in 1987 and in NEJM in 1992. D. Patients should not be considered candidates for calcium channel blocker therapy if they have RV dysfunction, depressed cardiac output, or WHO-FC4 symptoms. 3. Targeted therapies include prostacyclin derivatives, endothelin receptor antagonists, phosphodiesterase type 5 inhibitors, soluble guanylate cyclase S, GC stimulators, and selective prostacyclin receptor IP receptor agonists. G. Regarding prostacyclins, 1. Parenteral prostacyclins are used. A. They are recommended in patients with PAH with WHO-FC3 or 4 symptoms. B. Continuous infusion epoprostenol is the most thoroughly studied of the medications approved for the treatment of PAH and prolongs survival. 1. There was 100% survival with intravenous epoprostenol compared with 80% survival with conventional therapies at 12 weeks, published in NEJM in 1996. 2. There was 88% survival with intravenous epoprostenol compared with 80% survival in historical controls at 1 year, published in Circulation in 2002. 3. There was 55% survival with intravenous epoprostenol compared with 34% survival in historical controls at 5 years, published in the Journal of American College Cardiology in 2002. C. Complications related to delivery include the need for a dedicated intravenous line, local catheter infections or bloodstream infections, and catheter-related thrombosis. 2. Inhaled prostacyclins shown in Table 7. A. They are recommended for use in patients with WHOFC3 symptoms. Their advantages over intravenous route include selective pulmonary vasodilation with minimal systemic effects. B. 11 studies evaluated the use of inhaled epoprostenol, not FDA approved, in critically ill patients with PH, published in Pharmacotherapy in 2010. 1. Studies included patients undergoing cardiac surgery or lung or heart transplantation, as well as non-specific ICU patients. 2. Most studies showed a significant decrease in pulmonary pressures, however, significance with improving outcomes is unknown. 3. There were minimal adverse effects reported. C. Regarding inhaled iloprost. 1. There have been small studies of critically ill patients with PH. 2. It is not diluted in glycine buffer and no need for continuous administration. Pause the video and carefully scrutinize Table 7 summarizing available prostacyclins. H. Endothelin receptor antagonists are summarized in Table 8. 1. They have minimal place in therapy for critically ill ICU patients. 2. Macitentan is the only drug in this class with long-term data on morbidity and mortality. Pooled primary endpoint, worsening PAH to mortality, occurred in 31% of patients receiving macitentan compared with 46% of patients receiving placebo, with a p-value less than 0.001, published in NEJM in 2013. I. Phosphodiesterase type 5 inhibitors are summarized in Table 9. 1. Intravenous formulation are available for patients who temporarily cannot ingest tablets, however, they are limited by hemodynamic effects. 2. Improvement in RV contractility by increasing cyclic guanosine monophosphate inhibiting downstream phosphodiesterase type 3, exerting an inotropic effect, published in the British Journal of Clinical Pharmacology in 2011. J. We will now discuss S.G.C. stimulators. 1. Riociguat, marketed as Adempas, sensitizes S.G.C. to endogenous nitric oxide by stabilizing the nitric oxide S.G.C. binding. It also stimulates S.G.C. independent of the nitric oxide pathway. 2. It is approved for Group 1 PH to improve exercise capacity and WHOFC and delay clinical worsening. 3. Currently, Riociguat is the only medication approved for patients with Group 4 PH having residual chronic thromboembolic pulmonary hypertension (CTE-PH) after surgical treatment or inoperable CTE-PH to improve exercise capacity, published in NEJM in 2013. 4. Elimination half-life is 12 hours. 5. The approved dose is 1 to 2.5 mg 3 times daily, higher doses for smokers. 6. Its adverse effects include hypotension, hemoptysis, headache, dizziness, dyspepsia, nausea, diarrhea, vomiting, and anemia. 7. Contraindicated in patients receiving nitrates and phosphodiesterase inhibitors, avoid with strong CYP3A4 or 2C8 inhibitors and inducers and with P-glycoprotein or breast cancer resistance protein inhibitors. Pause the video and carefully scrutinize Table 8 summarizing ET receptor antagonists. Pause the video and carefully scrutinize table summarizing phosphodiesterase type 5 inhibitors. Next we will discuss selective prostacyclin receptor (IP receptor) agonists. 1. Selexipag, marketed as Uptravi, is a non-prostanoid that targets the prostacyclin pathway. It is indicated for the treatment of PAH to delay disease progression and reduce the risk of hospitalization, published in NEJM 2015. 2. Its elimination half-life is 0.8 to 3 hours and for the active metabolite, 6 to 14 hours. 3. Its approved dose is 200 micrograms twice daily, increase at weekly intervals to the highest tolerated dose, maximum dose, 1,600 micrograms twice daily. Adjustment is necessary for moderate hepatic impairment. 4. Its adverse effects are similar to those of other prostacyclins. We will now discuss managing decompensated pulmonary hypertension. 1. We should control contributing factors such as infections, arrhythmias, rebound pulmonary hypertension, non-adherence or ineffective dosing, hypoxemia, acidosis, and metabolic abnormalities. 2. Supportive therapies include optimizing RV preload, maintaining aortic root pressure, improving RV contractility, and reducing RV afterload. 3. Hemodynamic support is illustrated in Table 10. Maintaining aortic root pressure and minimizing RV ischemia can be accomplished using vasopressors, which increase the systemic vascular resistance and ultimately improve RV perfusion, published in Critical Care Medicine Journal in 2007. Direct effects on the pulmonary circulation from vasopressors may increase the PVR, potentially leading to further clinical decompensation. Few studies published to help guide the optimal vasopressor in patients with PH. Recommendations are extrapolations from other patient populations. Inotropes are used to further augment the cardiac output of the RV and may improve PVR because of systemic vasodilatory properties from inotropes. Expect possible systemic hypotension and need for vasopressors. 4. Unloading the RV with pulmonary vasodilators is essential to controlling decompensated pulmonary hypertension and RV failure. Pause the video and carefully scrutinize Table 10 summarizing agents used for hemodynamic support for decompensated pulmonary hypertension. We will now discuss the limitations of targeted therapies. 1. They are indicated only for patients with PAH. 2. They may result in worsening fluid retention, pulmonary edema, and gas exchange in other pulmonary hypertension groups. 3. There is limited data describing efficacy and safety in other pulmonary hypertension groups. 4. There is a small population size, primarily surrogate markers as outcomes measures, limited data in hospitalized and critically ill patients, and sparse long-term data. 5. Outcomes from combination therapy remain elusive. Next we will discuss asthma exacerbation. The classification of asthma exacerbations in the urgent or emergency care setting is illustrated in Table 11. 1. Asthma is a chronic inflammatory disorder of the airways causing recurrent episodes of wheezing, cough, chest tightness, or breathlessness that is often reversible spontaneously or with treatment, published in NAEPP guidelines in 2007. 2. Severe refractory asthma is defined as 1 major and 2 minor criteria, published in the American Journal of Respiratory Critical Care Medicine in 2000. We will first look at the major criteria. They include, treatment with high-dose inhaled corticosteroids or treatment with oral corticosteroids for 50% or more of the year. Minor criteria include, 1. Requirement for additional daily controller treatments, long-acting beta-2 agonists, theophylline, omalizumab, or leukotriene receptor antagonists. 2. Asthma symptoms requiring albuterol on a daily basis. 3. Persistent airway obstruction, with an FEV1 of 80% or less, peak expiratory flow rate of 20% or less. 4. 1 or more urgent care visits per year. 5. 3 or more oral corticosteroid bursts per year, and 6. Near-fatal asthma event in the past, requiring non-invasive or invasive ventilator support. 3. Asthma exacerbations are characterized by decreases in expiratory airflow that can be quantified by measuring lung function such as spirometry or peak expiratory flow. 4. Objective measures more reliably denote the severity of an exacerbation than the severity of symptoms. 5. Status asthmaticus is an acute, severe asthma exacerbation that does not respond to initial intensive therapy. 6. Near-fatal asthma is status asthmaticus that progresses to respiratory failure. 7. Regarding the patterns of near-fatal asthma, A. Type 1 refers to subacute worsening, accounting for up to 85% of cases. 1. It has a slow onset of symptoms in days to weeks. 2. It has poor response to inhaled bronchodilators. 3. Copious mucus, eosinophilic infiltration is present. B. Type 2 refers to acute deterioration, accounting for up to 20% of cases. 1. Its onset is over minutes to hours. 2. It has a marked response to bronchodilators. And 3. There is an absence of secretions, neutrophilic infiltration. Pause the video and carefully scrutinize Table 11 summarizing classification of asthma exacerbations in the urgent or emergency care setting. Pause the video and carefully scrutinize Table 11 summarizing classification of asthma exacerbations in the urgent or emergency care setting. B. We will now discuss mortality risk factors. They include 1. Prior episode of near-fatal asthma. 2. 2 or more hospitalizations in the previous year. 3. 3 or more emergency department visits in the previous year. 4. Hospitalization or emergency department visit for asthma in the past month. 5. Use of more than 2 canisters of short-acting beta agonists, abbreviated as SABAs, in the past month. 6. A social history that includes major psychosocial problems, illicit drug use, and low socioeconomic status. 7. Concomitant illnesses including cardiovascular diseases, psychiatric illness, or other chronic lung diseases. C. Next we will discuss alternative causes which mimic severe asthma exacerbation. They include 1. Upper airway causes e.g. vocal cord dysfunction, anaphylaxis, and laryngeal stenosis. 2. Central airway causes e.g. tracheomalacia, and tracheal stenosis mucus plugging. 3. Lower airway causes e.g. bronchiolitis, COPD, valvular heart disease, and diastolic heart dysfunction. D. We will now discuss arterial blood gas assessment. 1. Acute, severe asthma typically presents as a respiratory alkalosis. 2. As respiratory status worsens, arterial carbon dioxide increases, patient exhaustion, inadequate alveolar ventilation and/or an increase in physiologic dead space, leading to respiratory acidosis. 3. Metabolic, lactic acidosis may coexist. Lactate production presumably stems from the use of high-dose beta agonists, increased work of breathing resulting in anaerobic metabolism of the ventilatory muscles, and tissue hypoxia. Next we will discuss oxygen. 1. Oxygen therapy is an important component in the management of acute, severe asthma. 2. Oxygen by nasal cannula or mask should be administered to patients experiencing severe exacerbations with hypoxemia to achieve SaO2 values greater than 90%. Pregnant women and patients with cardiac history may require higher goals, published in NAEPP in 2007. Regarding non-invasive ventilation, data are insufficient for use in severe exacerbations. Next we will discuss mechanical ventilation. 1. Regarding its indications, it is used when a. There is worsening hypoxemia or hypercarbia. B. There is drowsiness or altered mental status. C. There is hemodynamic instability. And D. There is increased work of breathing. 2. Low minute ventilation by reduced tidal volume and/or respiratory rate, high inspiratory flow rate, and minimal PEEP on the ventilator will help minimize dynamic hyperinflation. H. We will now discuss beta agonists. 1. Short-acting beta agonists, abbreviated as SABAs, stimulate the beta-2 receptors on smooth muscle cells, leading to relaxation of respiratory smooth muscle and causing bronchodilation and a decrease in airway obstruction. 2. Short-acting beta agonists are the cornerstone in the management of acute, severe asthma, whereas long-acting beta-2 agonists and anticholinergic agents are not recommended in the acute treatment of a severe asthma exacerbation. 3. Patients with an asthma exacerbation should receive a short-acting beta agonists repeatedly with either an MDI or nebulization at presentation, and the short-acting beta agonists should be continued until resolution of acute symptoms, published in NAEPP in 2007. 4. Patients with severe acute exacerbations may benefit from continuous versus intermittent nebulization of short-acting beta agonists, published in Cochrane database SystRev in 2003. A. Intermittent dosing of albuterol entails administering 2.5 to 5 mg every 20 minutes for 3 doses, then 2.5 to 10 mg every 1 to 4 hours as needed. B. Continuous nebulization of albuterol entails administering 10 to 15 mg per hour 5. If albuterol is administered by MDI, the following must be considered. A dose of 4 to 8 puffs every 20 minutes up to 4 hours, then every 1 to 4 hours as needed. B. The canister must be removed from the actuator and connected to the inspiratory limb of the ventilator circuit with spacer. C. The actuation of an MDI must be synchronized with the onset of inspiratory airflow from the ventilator. D. A longer inspiratory time and slower inspiratory flow improve aerosol delivery in ventilated patients. E. Wait 15 seconds between actuations. 6. Systemic beta agonists, intravenous or subcutaneous epinephrine or terbutaline, may be considered if the patient does not respond to inhaled therapy after several hours. However, they have no proven advantage over inhaled agents. 7. Adverse effects include tremor, tachyarrhythmias, hyperkalemia, tachyphylaxis, hyperglycemia, and type B lactic acidosis. Next we will discuss anticholinergic agents. 1. Inhaled anticholinergic agents, such as ipratropium bromide, selectively bind to the muscarinic receptors on smooth muscle cells in the airways and thereby reduce bronchoconstriction. 2. They should be given in combination with a short-acting beta agonist to promote additional bronchodilation through a different pathway. 3. Adding ipratropium to inhaled albuterol compared with using albuterol alone in patients with severe asthma resulted in improved response. However, outcomes with this combination in status asthmaticus or near-fatal asthma remain elusive, published in the American Journal of Respiratory Critical Care Medicine in 2000. 4. See above albuterol MDI for administration technique on the ventilator. 5. Their adverse effects include headache, flushed skin, blurred vision, tachycardia, palpitations, and urinary retention. Next we will discuss corticosteroid therapy. 1. Corticosteroids decrease airway obstruction during an asthma exacerbation by decreasing inflammation, increasing the number of beta-2 receptors and increasing their responsiveness to beta agonists, reducing airway edema, and suppressing certain pro-inflammatory cytokines, published in Respiratory Medicine in 2004. 2. Systemic corticosteroids should be administered to patients who have moderate or severe exacerbations or to patients who do not respond promptly and completely to SABA treatment, published in the American Journal of Medicine in 1983. 3. Typically, there is a 6 to 8 hour delay in the response to corticosteroids in status asthmaticus or near-fatal asthma, therefore, administration should be considered early in the course within 1 hour of presentation, published in Cochrane database SystRev in 2001. 4. Oral prednisone is as effective as parenteral corticosteroids. However, it may not be beneficial in the critically ill patient with impaired gastric absorption. 5. Methylprednisolone should be dosed at 40 to 80 mg per day, or equivalent, in 1 or 2 divided doses until peak expiratory flow reaches 70% of predicted or personal best. 6. The duration of systemic corticosteroids for a severe asthma exacerbation requiring hospitalization may be 3 to 10 days. A. For corticosteroid courses less than 1 week, tapering is not necessary. B. For longer courses that is up to 10 days, there is probably no need to taper, especially if patients are concurrently using an inhaled corticosteroid. 7. Inhaled corticosteroids can be initiated any time in the treatment of an asthma exacerbation. We will now look at adjunctive therapies. 1. Ketamine is a phencyclidine derivative that has bronchodilatory properties through reducing airway resistance and preventing the reuptake of norepinephrine, which may stimulate beta-2 receptors, published in the Iran Journal of Allergy Asthma Immunology in 2003. 2. Helium-oxygen, also known as Heliox, is a blended gas, which is a mixture of about 70% to 80% helium and 20% to 30% oxygen, that decreases airway resistance, which leads to improved airflow and ventilation. It may delay the need for intubation by allowing other therapies to work. 3. Magnesium sulfate infusions may be considered in patients who have life-threatening exacerbations and are unresponsive to conventional therapies after 1 hour. Magnesium is thought to cause bronchodilation by inhibiting calcium channels on smooth muscle, leading to relaxation. B. In addition, magnesium may have anti-inflammatory properties that interfere with the activation and release of neutrophils in patients with asthma. Treatments not recommended include 1. Methyl K-S-anthanes, that is, theophylline and aminophylline. They do not improve lung function or other outcomes in hospitalized adults. 2. Antimicrobials are not generally recommended for the treatment of acute asthma exacerbations, however, consider using them if there is evidence of concurrent infection. 3. Mucolytics may worsen cough or airflow obstruction. Next we will discuss acute chronic obstructive pulmonary disease exacerbation. Definitions, Table 12:1. COPD is characterized by a chronic limitation in expiratory airflow that is not fully reversible. Chronic airflow limitation results from a combination of small airway disease, that is emphysema, and parenchymal destruction caused by inflammation, that is chronic bronchitis. 2. A COPD exacerbation can be defined as an acute worsening in the patient's baseline status, manifesting as an increase in dyspnea, cough, and/or sputum production, necessitating a change in medications. 3. General criteria for diagnosing an acute exacerbation are based on clinical presentation, including an acute change of symptoms that is beyond normal day-to-day variation. Arterial blood gas should be measured. B. Pulse oximetry can be used to determine the need for supplemental oxygen. C. Spirometry is not accurate during an exacerbation and is not recommended. Pause the video and carefully scrutinize Table 12 summarizing classification of COPD severity. B. We will now discuss the causes of acute COPD exacerbation. They include 1. Respiratory tract infection, representing 40% to 50% of COPD exacerbations. A. Regarding bacterial infections, 1. Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis are the most common organisms. 2. Pseudomonas aeruginosa is common in patients with Global Initiative for Chronic Obstructive Lung Disease, abbreviated as GOLD 3 and 4 severities. B. Viral infections caused by influenza, rhinovirus, parainfluenza, or respiratory syncytial virus. 2. Pulmonary embolism. 3. Pneumothorax. 4. Respiratory depression may be a result of the injudicious use of sedative and/or analgesic medications. 5. Surgery, especially of chest and upper abdomen. 6. Medication non-adherence. 7. Temperature change. 8. Air pollution. We will now look at oxygen. 1. Oxygen therapy is an important component in the management of COPD exacerbations, published in the GOLD 2014 update. 2. Oxygen by nasal cannula or mask should be administered to patients experiencing severe exacerbations to achieve an SaO2 of 88% to 92%, published in BMJ in 2010. 3. Caution is advised with oxygen supplementation in patients with COPD. A slight level of hypoxemia may serve as a trigger for their respiratory drive secondary to chronic hypercapnia. B. It may increase ventilation perfusion mismatch and decrease respiratory rate centrally and perpetuate the Haldane effect. D. Next we will discuss non-invasive mechanical ventilation. 1. It should be considered in patients with respiratory acidosis and severe dyspnea with increased work of breathing or clinical signs of respiratory muscle fatigue. GOLD 2014 update. 2. It improves mortality and respiratory acidosis and decreases the need for intubation and treatment failures. It decreases complications associated with invasive mechanical ventilation such as ventilator-associated pneumonia and hospital length of stay, published in NEJM in 1995. Next we will discuss mechanical ventilation. 1. Its indications include a. Failure of non-invasive ventilation. B. Severe dyspnea, acidosis, hypercapnia, or hypoxemia. C. Respiratory rate greater than 35 breaths per minute. D. Inability to clear respiratory secretions. E. Hemodynamic instability. F. And now we will discuss bronchodilators. 1. Inhaled SABAs, nebulized or MDI, with or without a short-acting anticholinergic, are the preferred agents for bronchodilation in COPD exacerbation, published in GOLD 2014 update. 2. The role of long-acting beta-agonists and anticholinergic agents remains unclear in acute exacerbations in the critically ill patient. Next we will discuss corticosteroid therapy. 1. The dose recommended by the guidelines is 40 mg of prednisone equivalent daily, preferably oral, for 5 days. If oral administration is not an option due to altered bioavailability of corticosteroids secondary to hypoxemia or fluid overload, equivalent doses of intravenous hydrocortisone or methylprednisolone or nebulized budesonide may be administered, published in GOLD 2014 update. 2. Systemic corticosteroids in non-critically ill patients reduce the risk of early relapse rate, treatment failure, and hospital length of stay and improve FEV1, published in NEJM in 1999 and in CHEST in 2001. 3. The REDUCE trial, an abbreviation for Reduction in the Use of Corticosteroids in Exacerbated COPD, was a randomized, non-inferiority trial. Patients were randomized to prednisone 40 mg daily for either 5 or 14 days, inhaled bronchodilators and antimicrobials in both groups. COPD exacerbations occurred in 35.9% of patients in the 5-day group and in 36.8% of patients in the 14-day group, with a p-value equal to 0.006 published in JAMA in 2013. This study did not include critically ill patients requiring mechanical ventilation. 4. Let's now look at studies including ICU patients. A randomized, double-blind trial including 83 adult patients with a COPD exacerbation requiring hospitalization and ventilatory support, invasive or non-invasive, compared methylprednisolone 0.5 mg per kilogram intravenously every 6 hours for 72 hours, 0.5 mg per kilogram every 12 hours on days 4 to 6, and 0.5 mg per kilogram daily on days 7 to 10 with placebo. Patients receiving corticosteroids had a shorter duration of mechanical ventilation with a p-value equal to 0.04, shorter length of ICU stay with a p-value equal to 0.09, less non-invasive ventilation failures with a p-value equal to 0.004, and more hyperglycemia with a p-value equal to 0.04. This study was not powered to detect differences in length of stay or mortality, published in the Archives of Internal Medicine in 2011. B. An open-label, randomized trial included 217 critically ill patients 40 years and older with COPD exacerbation requiring mechanical ventilation to receive oral prednisone 1 mg per kilogram daily for a maximum of 10 days or usual care. No significant differences in ICU mortality, non-invasive ventilation failure, duration of mechanical ventilation or ICU length of stay were observed, although the study did not meet power. Hyperglycemia significantly increased in the steroid group, published in the European Respiratory Journal in 2014. A cohort study compared high dose, that is 240 mg per day or greater, with low dose, that is 240 mg per day or less, methylprednisolone in over 17,000 patients with a COPD exacerbation admitted to an ICU. Patients in the high-dose group had longer ICU and hospital lengths of stay, higher hospital costs, longer duration of mechanical ventilation, and more hyperglycemia and fungal infections. No differences in mortality were observed between the two groups, published in the American Journal of Respiratory Critical Care Medicine in 2014. 5. Next we will discuss the use of antimicrobials as published in Cochrane database SystRev in 2012. A. They should be administered if one of the following is met. 1. All three cardinal symptoms of a COPD exacerbation, that is, increased dyspnea, sputum production, and sputum purulence, are present. It is supported by clinical trials, but there is limited literature. 2. Two of the three cardinal signs are present, with increased sputum purulence as one of the symptoms. It is supported by non-randomized and observational trials. 3. The patient requires non-invasive or invasive ventilation. It is supported by clinical trials, but there is limited literature. B. We recommended duration of antimicrobials is 5 to 10 days. C. Optimal antimicrobial therapy is not established, however, should be based on local resistance patterns. H. Regarding Helix, its effect may be minimal in a COPD exacerbation because small airways in the lungs are largely affected when flow is laminar rather than turbulent. I. Treatments not recommended include doxapram or other respiratory stimulants. Thank you.